Welcome, everybody. I'm Amy Coote. I'm the Chief Executive Officer at Maddie Riewoldt's Vision. I'd really like to welcome everyone to our second patient and family educational session on bone marrow failure syndromes for 2025. I'd like to start by acknowledging the traditional custodians of the lands of which we are all gathered this evening. For me, I'm on the lands of the Wurundjeri people of the Kulin Nation. I like to pay my respects to their elders, past and present, and extend that respect to any Aboriginal or Torres Strait Islanders joining us this evening. As many of you do know, Maddie's Vision is the only organisation in Australia dedicated to bone marrow failure syndrome research, advocacy, education, and support for patients and their families. This is our 10th year since the Riewoldt family lost Maddie to aplastic anemia, but they've been able to amazingly channel that grief into an incredible legacy and 10 years of important impact. We've now funded $9.7 million across 36 cutting-edge research projects and have multidisciplinary collaborations in place with 23 leading medical research institutes, hospitals, and universities across Australia and internationally. We are the main source and only source of support for bone marrow failure syndrome patients and families across Australia, and are very proud to offer our tele support service and peer support programs, as well as these important educational opportunities to our patient and family community. To date, we've supported over 150 patients and their families across Australia. And if we haven't connected with any of you tonight through those important services, please do reach out. We are here for you if you need us. I now have the absolute pleasure of introducing Professor Erica Wood, AO, who will be chairing this session this evening. Erica is a haematologist at Monash Health and head of the Transfusion Research Unit and the School of Public Health and Preventative Medicine at Monash University. Please join me in welcoming Erica. Thank you so much.
Hello, everyone. Thank you, Amy. It's such a pleasure to be here with all of you this evening. And I'll be chairing, and our program this evening will focus on two important research initiatives: the Aplastic Anemia and Other Bone Marrow Failure Syndromes Registry, known as the AAR, and the Australian Marrow Failure Biobank, the AMFB. Dr. Lucy Fox and Professor Melissa Southey and I will share how these programs are driving research into better treatments and cures, and explore the processes, many challenges and many opportunities involved in participating in research, and how you can get involved. We hope that tonight we can help demystify what it means to contribute to these vital efforts. Following our short presentations, we'll have a 30-minute Q&A session, and some people have already submitted questions prior to today. Thank you very much. We will try to cover these in the presentations tonight and in the discussion, but if you'd like us to expand on certain topics, then we'll try and cover those during the Q&A and or afterwards. So I will be the first speaker, and just give me a moment while I share my slides, and then we will go from there. One moment. Righty-ho. Now, can everybody see this slide, and how does that look? Super. Thank you very much for confirming. So I'm just going to set the scene for the other two speakers by giving a little bit of background about what registries are. And our group runs a number of registries, and as well as the AAR. So I think I'm well placed to address this, and then I'll hand over to Lucy to speak about the AAR, the Aplastic Anemia Registry, and other bone marrow failure syndromes. But if you have any questions for me, I've put my email here on the screen. I'm just going to reduce the participant view so that that doesn't get in the way of any slides. So this is our group at the Transfusion Research Unit at Monash University, and my own personal area of expertise is in transfusion research. It's definitely time for another team photo because we've got a lot of people who couldn't be there on the day of our last team photo. And our focus is on improving treatment and outcomes for people with a range of blood disorders or who might need major transfusion support. And many people with bone marrow failure syndromes, as you know, might need transfusion support for weeks, months, or even years. So the kinds of blood diseases we focus on are for people with blood cancers, bone marrow failure syndromes, other inherited and acquired disorders such as thalassemia and sickle cell disease, and major bleeding, such as that people might experience from trauma or other causes of critical bleeding and major hemorrhage. We're situated in the School of Public Health and Preventive Medicine at Monash University. We're Australia's largest school of public health. And we literally wrote the book on good clinical quality registry practices. And all of these are freely available online if people would like to read more about registry science, which is a whole field in itself. Sorry, just having a moment, advancing my own slides. And our School of Public Health manages more than 40 registries. Some of them you can see here. And the first one alphabetically is the aplastic anemia and other bone marrow failure syndromes registry, the AAR. And you can see some of the other ones on the screen, everything from burns to trauma to myeloma and lymphoma, which are types of blood cancers, and hemoglobin disorders, which are inherited. And there's a whole portfolio describing our work. So why are we so interested in registries? So a few years ago, nearly more than a decade now, this report was published called the McKeon Report. And it was a government-commissioned report, a strategic review of health and medical research in Australia. And one of its very important and interesting findings was about the role of clinical registries. And to quote from that report, the group said that clinical registries, which systematically collect information on treatments and their outcomes from hospitals across clinical practice guidelines, are one of the most effective means of monitoring and encouraging the uptake of medical and healthcare guidelines. And this, of course, is relevant to research because guidelines are based on available evidence. If you don't have evidence, it's very hard to write guidelines. So maybe it's important just to help set the scene for Lucy's presentation to explain so that we're all on the same page about what is a registry. So it's an observational data set. It's not an interventional type of research. We are not directing what happens to people in their situation, what kind of treatment they should have, for example. It's conducted under the oversight of an ethics committee and with governance approval from every participating hospital. Registries can help describe the epidemiology, so patterns of a condition in a particular population. And in order to do that, we want to make sure that all eligible participants are included. So we need to think about what might be barriers to participating in a registry. You can imagine that for rare conditions, having everybody participating who is eligible is very important. A little bit like putting pixels together to make an image that we can all see. And registries can help us systematically monitor the quality of care, so the clinical appropriateness and the effectiveness in terms of outcomes, by routinely collecting and analysing data on practice and how that practice might vary, and clinical outcomes for people with the condition. Some types of registries might collect information, for example, on a particular procedure, some kind of orthopedic procedure, for example. Others would collect information on particular conditions. So there is a lot of variation in how registries might work. Importantly, they can also describe the need for and uptake and costs of new therapies. And we're all hoping for new therapies in the bone marrow failure space. And then registries can provide feedback on current practice and where practice could be improved so that hospitals can use these for benchmarking and quality improvement. And down on the bottom right here, you can see a schema of what this might look like. So starting at the top, routine data are being collected every day by hospitals, by clinicians taking care of people. They can securely share that with the registry. There are a whole bunch of regulations and guidelines governing how registries should work. The information can be compiled and analysed in the registry. We can provide feedback to the individual clinicians and the hospitals. They can use that to improve clinical care. And then we can continue this cycle by seeing how care improves over time. So registries are long-term projects. They're not something you set up for 1 year or 5 years. They're something you set up for 10 or 20 or more years. And here are just some examples. So on the left here, you can see an example from one of our other registries in blood cancers and lymphoma, the kinds of information we collect and when we do that. So at baseline, some demographics and characteristics of the participants, some therapy information, and then information at periods of review, so 6 and 12 months and then annually. And then on the right, you can see some examples of how registries can provide that feedback. And this is not feedback from the lymphoma registry or the AAR. But if you look here on the top right, this is an example of how participating sites in a registry who were, for example, collecting information after cancer surgery. If you were that red dot at the bottom, your hospital might have some work to do. But it also is interpreted relative to the number of cases you've reported over time. And at the bottom here, you can see a theoretical example of how we could monitor after organ transplant for particular conditions. And again, if you were the hospital in the red at the bottom with the lowest survival, you might want to look at your patients and practice and outcomes and say, how can we improve? This is not about naming and shaming people. This is about providing data back to hospitals so they can improve their practice. Registries can also help us because they can serve as a platform for clinical research, such as clinical trials. And we know that clinical trials often exclude many people with a condition for all sorts of understandable reasons, but it might mean that the trial population is not very representative of the real world. And in rare conditions, this can be very important because it might be impossible or impractical to conduct clinical trials. But registries can provide information based on data in the registry that could help you develop a hypothesis, provide pilot data. How many people are there with this condition? Where are they? What is their outcome? And maybe a way to host the clinical trial so that you can collect data faster to get started. You can have longer term follow-up and reduce costs of establishing a new trial. And as Lucy and Melissa will explain later, these link very nicely with other types of research, including biobanks. So what are the differences between a registry and a trial? As I've just mentioned, a trial might be very robust in the data that it collects. It may focus on a single hypothesis, but it may have very limiting inclusion and exclusion criteria from a limited sample of the population. In the trial, we will control for things like confounders and variables that might influence the results. And the trial is basically determining what will happen. In a registry, we might be able to collect more data, but it may be less robust than in a narrow clinical trial. We may be able to look at more questions. We'll have broad inclusion and exclusion criteria and aim to represent the whole population. We have to understand that this is observational, so there might be confounders and variables that influence our findings, but we collect data about what does happen. So registries are now recognised by the Australian Commonwealth and State Departments of Health as being highly valuable. And you can see here just a little extract from this report from the Commonwealth Department of Health about the value in terms of patient outcomes, standardising our practice, and also being part of important innovation activities for impact to impact on people's health and also how the community money is spent. Then my last slide is to say that it costs money to run a registry. Registries are infrastructure. We need to establish them, manage them, keep them going, make the best use of them. But here you can see a report from the Australian Commission on Safety and Quality in Healthcare, which was an economic evaluation of clinical quality registries, which showed a return on investment ratio of between 2 and 7 to 1. And you can see just some examples here: prostate cancer, trauma, intensive care, and dialysis, about the value to the community. So this is thought to be a very good value. And if you're interested in reading that report, please do so. So I'll finish by saying thanks to everybody who's participated in the registries, all the site investigators and staff, our steering committee, and of course to Maddie's vision. And I'll just say one last word because I'm a blood transfusion person. Please be a blood donor if you can, because many people, including people here tonight, will need substantial transfusion support. So this might be a way that you personally can participate in research. So I'm going to stop sharing my slides and then I'm going to introduce our next speaker. I think I've stopped sharing. So it's now my pleasure to introduce Dr. Lucy Fox, who is a haematologist at the Peter MacCallum Cancer Centre and a clinical research fellow with us at the Transfusion Research Unit at Monash University. And Lucy's going to give us an update on the aplastic anemia and other bone marrow failure syndromes registry, and also how people can participate more broadly in research. Thanks, Lucy. Over to you.
Thanks, Erica. Good evening, everyone. So it's a pleasure to talk about the AAR. You can see Erica's mentioned our long-winded title for the registry because we cover so many diseases in our registry. So we shorten it to the AAR. So the AAR is a collaboration of over 40 hospitals around our country, and it's a network of clinicians and other staff in the hospital who are interested in bone marrow failures, and I'll go through the diseases in a second. And one of the powerful things that our collaboration lets us do is learn from each other, but also work with people overseas in different research groups internationally to further our knowledge and research efforts. And for people who may be on the line with a telomere biology disorder, there's a very important research group called CCCTAA that we collaborate with really closely. If anyone has Shwachman-Diamond syndrome, there's an international working group with whom we share, with whom we work a lot on a lot of research projects. And so our registry aims to collect information about patients all over the country with a bone marrow failure syndrome, with any bone marrow failure syndrome. And our dream is that every patient who wants to participate has the opportunity to do so. And Erica touched on this, but one of the important things about our registry is that it provides infrastructure to support other studies, and I'm going to touch on them in a second, and we'll hear about the biobank from Melissa. And the registry also provides an important educational role. So we have seminars such as this, but it also lets our young research colleagues participate in research. And we're really lucky this year to have two new haematologists who want to further their bone marrow failure research, and they're undertaking PhDs with our team. So I won't dwell on all the diseases because it is incredibly complicated, but just to say that we are really interested in any kind of bone marrow failure, whether that's acquired disease such as immunoaplastic anemia, which is an acquired disease where the immune system attacks the bone marrow stem cell compartment, or inherited diseases. So those traditional inherited diseases, we call them traditional bone marrow failure syndromes, such as Fanconi anemia or a telomere biology disorder. But there's also a range of new inherited diseases that we've only been learning about in recent years because we've got such better access to genetic testing now, and people on the call may have an inherited mutation in a gene such as GATA2 or RUNX1. So we run the registry because we want to understand where the need is in this country, where all patients are with aplastic anemia and all bone marrow failure syndromes. We want to know what kind of what the diagnoses are and what treatments patients around the country are having. And if someone has an inherited bone marrow failure syndrome, we want to know exactly the nature of that, and if we know it, the exact genetic change that underlies their condition. We want to know what factors influence how patients their outcomes, and what factors can be used, what things can we use to improve the outcomes, because we know that people with bone marrow failure syndromes can sometimes have a really difficult clinical course. And what we want to do is build a community where we collaborate and inspire research into all aspects of bone marrow failure. So here are the sites around Australia that are currently participating, and you can see we've got pretty good coverage in many states. That our outlier is the Northern Territory. Hopefully one day we can open in that state. But you can see, I want you to have a look and see if you or your loved one is cared for at one of these hospitals. That means that we can enrol that person in our registry if you want to do that. So this is the kind of data that we collect. We are interested in the registry in collecting clinical information. So we want to know what a patient is like at baseline, which is when they really first become known to the hematology team. And we want to understand all aspects of their diagnosis, how they presented, all their investigations. We want to know what they're treated with, if they need treatment. We know that many patients with bone marrow failure syndromes undergo a stem cell transplant, and we want to understand that. And you can see on the far right, we do initial presentation, then we ask for a 6-month update, then a 12-month update, and then annually thereafter. And our hope is that we can collect long-term information on people right up until the point of their death, because we want to understand if a person dies from a bone marrow failure or complications of their treatment. So here is our accrual to the registry, and you can see that we're now up to over 600 patients around Australia who have experienced who are experiencing a bone marrow failure syndrome. And like Erica said, it doesn't happen overnight. It is a real slow burn, these projects, but we have a lot of momentum at the moment, and we have lots of people who are interested in participating in the registry. And now it's up to the clinical team, so myself or colleagues at other hospitals, to get all of you who are interested enrolled in our registry. These are the kinds of the diagnoses that patients in our registries have, and you can see the most common one is idiopathic or immune aplastic anemia, because that is the most common bone marrow failure syndrome that we see. But increasingly, we're seeing genetic diagnoses and things such as DDX41, Diamond-Blackfan anemia, Shwachman-Diamond syndrome. These are all things we know that many patients now around the country and their families are experiencing. So these are this is an example of some of the projects that the registry can support. And one of them is the Diamond trial. So this is a clinical trial that we ran using the registry as a platform. So the registry captured the clinical data of patients with immunoplastic anemia who had a novel drug, avatrombopag, and we wanted to see the effect of that drug on treating their bone marrow failure. And that's been a really successful clinical trial, which was built off the backbone of the registry. Another study that we participate in is run by Piers Blombury and myself out of Peter McElroy, Melbourne, where we are doing a genetic study where we want to understand exactly why a person has the bone marrow failure that they have. And I mean with pinpoint accuracy to the level in the DNA. And we got a big grant from the MRFF, which has let us do this study, which we're in the closing phases of to a couple of hundred Australian patients with bone marrow failure. And this study is really building off a previous study that we did over here on the right, another genetic testing study. And through these genetic testing studies, we have given a lot of Australian patients the opportunity to enrol in our registry. And we want to understand, as I said before, their long-term outcomes. So this shows you how our registries are linked. So our registry links with other projects, and I mentioned the Diamond trial and the IBMDX study, and you're about to hear from Melissa about the biobank, which we're really excited about. So I'll finish there and hand over back to Erica and Melissa, but just to acknowledge the people who have worked on this project over many years. So over here on the right is a picture of us at the Bone Marrow Failure Symposium that we hosted at the Victorian Cancer Centre earlier this year, a really successful event sponsored by Maddie's Vision, and it lets a lot of our collaborators who work on the aplastic anemia registry around Australia come together and learn more about bone marrow failure syndrome research. So I'll stop there.
Oh, thanks so much, Lucy. Fantastic presentation. I'm sure people will already have questions that they'd like to follow up after the next speaker. So thank you very much. And I'm really delighted to introduce our next speaker, Professor Melissa Southey, OAM. She is the Chair of Precision Medicine at the School of Clinical Sciences at Monash University and Director of Biobanking Victoria. And she'll give us an overview of the new Australian Marrow Failure Biobank and how it supports bone marrow failure syndrome research. Thanks so much, Melissa.
Well, thanks very much for the introduction, Erica, and the nice background that helps me present this a bit more succinctly, I hope, Lucy. Yeah, but as Erica said, it's really exciting to talk about the biobank in the context of the registry tonight because it is a more recent initiative, and an initiative that is now up and operational, and provides an extra dimension, I think, on the sort of research that can be done in the area of bone marrow failure. Okay, so this circle represents, as you've seen in other slides, the registry, which you've heard a lot about, and we've been really lucky to be able to link this to what we call the Australian Marrow Failure Biobank, which provides central storage for biological samples, really with, I think, three key missions to increase activity in research and the understanding of bone marrow failure, all of the syndromes that fall under bone marrow failure. So I'm just having a little bit of trouble seeing my slides. So like Erica, I'm moving pictures around. Okay, so the main mission really is to collect and store biological specimens that can be made available to the research community. This doesn't just mean researchers in Victoria, which is where the biobank is based, but researchers throughout Australia and actually researchers internationally, like the registry has done to connect research initiatives across the world so that we can together find answers to our questions more quickly than we could individually. I think this is especially relevant to rare diseases, which really is the context of our conversation today. And with increased international collaboration, we really hope that the biobanking activity will identify new ways to diagnose and treat bone marrow failure syndromes. Okay, so just really generally, the place where the most important conversations about biobanking happen are really in the clinic. So in the context of a patient attending an appointment with their doctor, their usual appointment, it's not made especially to consider biobanking usually. It can now be raised at the possibility of providing biological material to the Australian Marrow Failure Biobank. So at the moment, after an amazing amount of work that's been done to put the administrative mechanism in place, we are now able to recruit participants into the biobank and their biological samples from the Peter MacCallum, from the Perth Children's Hospital, from Concord General Hospital, from the Austin Hospital. And we continue to work with other hospitals to try and increase the number of hospitals from which we are able to recruit participants into the biobank. As you'll see, our aspirations are probably very large because you saw the number of participants in the registry in Lucy's slides. So we're really hoping to expand this. And now that we have the principles and the understanding of what's required to have approvals in place to be able to do this, I hope we'll be able to expand the number of sites that can collect biological materials for the biobank in the near future quite substantially. So the conversation between the clinician and the patient about biobanking is a really, really important one. And it has many attributes that can perhaps be condensed into these subheadings. Firstly, eligibility. And as Lucy described, we're really including all of the bone marrow failure syndromes in this biobank. And so the eligibility is quite broad. And participants can be newly diagnosed or existing cases. They can be relatives of people with bone marrow failure syndromes. They can be adults or children. And people can provide permission for others to participate in the biobank, so a parent can provide permission for a child and so forth. I'm trying to make this as broad as possible so as many precious biological specimens can be collected for research as possible. So another really important aspect of this is what we call consent. So this is making sure that the person who's being the person in the discussion about biobank really understands what's being asked of them and what the opportunity is for them to provide biological specimens. We provide a lot of written information, but there's also a really important dialogue between the doctor and the potential participant about what this involves and what the ongoing use of their specimens will be involved in. And then there's, of course, the very important participant registration, where the participant gives permission for their biological samples to be given and for them to be stored in the biobank for research. And then there is sample collection. And for these sorts of studies, we're interested in all sorts of really precious samples that can be collected from a participant to contribute to research. And this can include samples of bone marrow, samples of their peripheral blood. It can include buccal swabs from inside their mouth. It can include hair with a hair follicle that we can get things like DNA from, and can include nail clippings. So it's really amazing what sort of biological materials can be used in really interesting research that might inform and give further understanding of many of these conditions. And these samples can be collected at many time points. So it can, as I said, be done at the appointment with their usual doctor in the usual appointment. It can be done on an annual basis. And it can be done fortuitously if the patient needs to come into the clinic for other reasons or related reasons, which are all really important. And it's especially nice to get multiple samples over a time period for a patient to understand how their disease is either responding or not responding or progressing over time. So just to give you a small insight into what a sample collection kit looks like, this is what it looks like. This has been developed over some time with a number of people much more expert than me about what's required in these contexts, but it is a package sent to all the participating hospitals so that when somebody agrees to provide biological specimens for the biobank, the collection kit is ready to go and the specimens can be collected as efficiently as possible for the participant. So you can see tweezers and scissors and blood tubes, and they all get packed up into a very safe package for shipping back to the biobank. So this is often actually the trickiest part of good biobanking, and that is shipping the material. So there's been this really generous contribution of biological material from our participants and a really important conversation with the clinician to understand what that is providing to researchers. And then we have to move it sometimes across the country. And some of the specimens, like blood, need to be done really quickly. We like to get the blood back into the biobank within 24 or 48 hours, and sometimes it requires aeroplane trips in cold packages and express shipping. But other things, like fingernail clippings and so forth, we can use good old Australia Post. It can be as slow as it likes because nothing's going to happen to your nails. So we're happy to receive that in a slower pace. But some of the specimens, it's really nice and really important to get into the biobank as quickly as possible. So the Australian Marrow Failure Biobank is the resources and the biological material are managed in a facility called Biobanking Victoria, which is based at Monash University. And this is a facility that manages about 52 biobanks at the moment. The AMFB is one of them. It's a piece of infrastructure that has NATA accreditation, which is the only accredited biobank in the country at the moment. That means it meets some measures of quality management across the systems that we use to receive, manage, and store the biological specimens. So here is just another illustration of the sorts of samples that we collect. We collect blood in different types of blood tubes to do different sorts of experiments. Some blood tubes are very good for preserving whole cells. Some types of other tubes are really good for preserving DNA and RNA really well for different types of analyses that we imagine people will want to do their research in the longer term. So these are all processed in a way that they're not stored in the large tubes that arrive into the biobank. They're processed and fractionated so that we have multiple aliquots of each of these biospecimens, and they're stored either in our -80 freezer facility, which is on the left-hand side here, or in liquid nitrogen at a -190 degrees, which is on the right-hand side. And this is also a really important part of our biobanking because some samples sit in this facility for decades, and actually the longer they sit there, often the more valuable they are for research because the person has had time to travel across their disease and their experience. I think Erica's discussion about the registries, she noted that some of the most valuable registries are the old ones that have followed people for a very long time across their life. And in fact, we think my experience is that some of the most valuable biobanks are those linked to registries. So we were really pleased to be involved with the AMFB with Erica and Lucy. So these samples sit in a very highly managed environment. You can see a lot of the control things hanging down from the ceilings. So they have a lot of temperature monitoring. They have 3 layers of alarms. Some go into our university system, but a lot come directly to our mobile phones if we need to react quickly to any sort of fluctuation in temperature, any sort of instrument failure, anything that might put any of our really precious biological material at risk. And perhaps for my last point, I would just say that the responsibility of managing these biospecimens and their related data is pretty enormous. So we take great care in governing the use of the material. So we're really pleased now to have biological material in the Marrow Failure Biobank, and very shortly we'll be able to put this mechanism into place where researchers can apply to a special access committee for access to material that we have in the biobank to support their ongoing research. Of course, every specimen is extremely precious, so we're very careful to make sure that it goes to the best research possible that will have the highest likelihood of contributing to the advancement of the understanding of bone marrow failure diseases in the short rather than longer term. Without going into all of this governance structure, we've worked fairly hard to make sure that it is robust and that we care very much and respect the very great contribution people have made to the biobank for ongoing research, particularly on the biology of bone marrow failure. And again, it's always very hard to take a photograph because the moment you take it, it's out of date. But this is the biobanking team at Monash University. The most critical person is in the centre. It's Helen Smeekus, who's managed this facility for a large number of years in an expert way that has enabled us to respond positively to approaches like that from Erica about, we have this registry, we want biological material too, let's do it. And so we did. And it's been a great thing. And I really hope now we're in a position to really increase the trajectory of increasing knowledge around these bone marrow failure syndromes. So thank you, Erica.
Thank you, Melissa. Fantastic overview of biobanking and how it's important in the bone marrow failure syndrome space. So we've got now a number of, we've got 20 minutes or so for questions and discussions. We've received a number of excellent questions already online. If you've got questions tonight, please, you can put them in the chat. We'll try and get to most of the questions. Some of the questions we've already received are about the diagnosis and management of bone marrow failure syndromes. We'll try and do justice to some of those. We know lots of people have questions. We may not be able to discuss all of those tonight, but we will try and respond to the majority. As we start, can I ask one of the questions that's been previously submitted to Lucy, which is, I'm not sure if I can participate or my family can participate in the registry. What is the process of going about this, and how do I even know if my hospital is participating?
Sure. So that's a really important question, because our system that we have here in Australia is pretty unique to the Australian system, the Australian setting. And what I mean by that is that to be eligible to participate in the registry, you need to be cared for at one of the hospitals that has ethics in place to enrol patients in the registry. And so I showed you the map before there, all the sites that are currently participating in the registry. And if you are at one of those sites, you can ask your doctor about how to do it. Now, your doctor might not have all the answers, because not all hematologists or bone marrow transplant specialists, are actively enrolling patients in the registry. And that's because it often falls to what we call the chief investigator or one of their delegates to do the legwork, if you like. But really, if you are at one of those hospitals, then you will be able to be enrolled, and it's just a matter of finding the right person in the hospital to do that. And I take a lot of questions from doctors about how to go about doing it, how to get a login, how to give the patient the appropriate paperwork. And so in the first instance, it's talking to your doctor. And if your doctor says, "Oh, I don't know what to do," say, "Well, can you email Lucy Fox, or can you email the registry and find out?"
Sorry, there's always someone who's on mute when they don't mean to be. That's me just then. So a couple of related questions, which is, how do I know that our family are on the registry? And another question, if our hospital is involved with the registry, do we as a patient need to raise it with our treating team?
Yeah, so I'll take the second question first, because I do need to recognise the differences with some other international registries. So, for example, the Severe Congenital Neutropenia Registry that's run out of the States, but which is open to people from a few different countries, they have a mechanism where the patient just gets online and self-refers and signs a bit of paperwork online, which essentially lets the registry team interrogate their clinical data, go into the hospital system data and request their data. Now, that is a nice framework to have, and in some ways it would be easier, because yes, it lets the really interested and keen patient take control of it a bit. That's not the kind of ethical framework that we work in Australia, and so as Erica showed you before, our group has a lot of experience with registries and getting people onto registries with different diseases, and our current approach is the accepted way in Australia, and maybe that will change in future years. But at the moment, it needs to be, one needs to be enrolled by their treating hospital. And so how do you know that your family's on the registry? Well, if you are a person who's got a relationship with a clinician that you see regularly, you can ask your clinician what should happen. So I didn't touch on consent talk because I didn't want to muddle things, but our registries at the moment, it's called opt-out consent. So what happens is in your clinic appointment, your doctor says there's a registry, this is what it's about, here is an information brochure. And if you'd like to participate, that's great, but if you don't, let me know and we won't enroll you. So you might have had, if you've had one of those conversations with your doctor, and if you got the brochure, then you probably are on the registry. And if you feel like you're not getting any answers, your doctor says, look, I don't know how to look up. Again, that is a time when you can email the registry, and one of our staff or myself can get in touch with your treating doctor and work it out.
Thank you, Lucy. So if people need more information, is my hospital on the registry? Have a look at the website or contact us. I've just put the email address for us in the chat. Our team is extremely friendly and happy to help. Not every single hospital in Australia is on the registry, but the majority of large hospitals looking after people with bone marrow failure syndromes are on the registry, and we're always happy to take questions. Melissa, there's a question about whether can you as a patient through your treating team offer to participate in the biobank, or is it currently restricted to those locations already listed?
So currently we only have, as Lucy said, ethics in place, which is a really important thing to have in place to recruit from the hospitals that are listed on my slide. But we are working to increase the number of hospitals that we can recruit from. So if it's not currently your hospital, we hope we will get there soon. But it would also be worth raising it with the clinician that you see so that they are perhaps aware of the possibility. One of the things that is required to get our hospital involved is hospital staff time, and that's often a very precious thing. It's extra work to get these things in place, and I think if the hospital staff, including the clinicians, hear it from patients that they're interested in this, I think it might raise the awareness and perhaps raise the priority in their really precious time to put to the work that's required to enroll the hospital in the biobanking activities and the registry.
Thanks, Melissa. I could also add to that, as Melissa has mentioned previously, we're rolling this out in a pilot way. So I can say, as someone who runs more than 10 registries, that we've learned a lot along the way as we've managed various registries and other biobanks associated with registries. It's good to learn things when you've only got 2 or 3 or 4 hospitals participating. You don't want to roll things out at 50 hospitals and then realize, oh, there's some important issue that needs addressing. So we always start with a pilot, whether it's a new registry or a new biobank. And this allows everybody to learn and get familiar with the process. And it does take time for hospital staff to get familiar with the process. And that's very important because we can also get some very valuable feedback from participants and from hospital staff. I'm going to take a few other questions from some of those that were submitted earlier. Can I be included in the database is one of the questions that we received earlier. Maybe Lucy, you might like to answer that one.
Yeah, so I think that question is from a person asking if they can, be included, and the mechanism for that is, like I said before, the crucial thing is that you are cared for at a hospital that has the ethics, and like Erica said, unfortunately, not all hospitals have ethics in place, and there may be some people who are quite appropriately cared for, in the private system, where the participation in the registries is less active, I guess. we are open to private places, private hospitals enrolling patients, but there is that little bit of work involved in getting the ethics all up and running, and that's doable. We've got, our team is really up to supporting a clinical team with getting their hospital and all the paperwork on board, But the statement I said before, our dream, it's the dream of everyone on the line at Maddie's Vision and the registry and the biobank. We really want to work towards every person with one of these conditions, whether they're a kid, whether they're an adult, whether they're 80, being able to participate in this. So we're constantly looking at our processes, our consent processes, things like that, to try and work out how we can facilitate everyone having the opportunity.
Thanks, Lucy. And to answer a question, who says, can you as a patient through your treating team offer to participate in the biobank, or is it currently restricted to those locations listed on the slides? Yes, we are starting with a biobank pilot, but if people are saying to their treating team, I think we should be in this pilot, let's get involved. Certainly that will help a lot in people saying, yeah, we should do this. There's also a question from Leah who says, I believe we're on the registry, but not biobanking. We go through John Hunter Children's. Would we be eligible for biobanking? I think the more we can have feedback from patients and families saying, yes, we want this to happen, we want this to be national, we want this to proceed, all of this will definitely help. As Lucy and Melissa have said, clinicians are very, very busy. They've got a lot of demands on their time, and it can be particularly challenging in rare conditions to be front of mind for some of these conditions. But I think that's where input from patients and families can be really important. There's one other question with bone marrow failure syndromes that affect multiple organs. Is the registry interested in all aspects of the syndrome or just the bone marrow aspect? Lucy, if you might like to have a look at that one.
Yeah, so it's absolutely all aspects of the syndrome. So we know that several of these conditions involve multi-organs, and so whether it's the liver, the lungs, the skin, we know that yes, these conditions can have significant effects, and so we do collect. We've got specific questions that ask, for example, about the lungs in the telomere biology disorders or the gut function in Shockwin-Diamond syndrome. So we do ask about that. And, the more I get involved in this work, the more I understand, the more data I want to collect. We have to be reasonable about how many fields that we have in the registry. But, we were asked to participate. In the telomere biology group had a specific project where they were interested in bone health in people with telomere biology disorders. And, we looked at participating, but we couldn't quite do it because we didn't have, access to things like every single bone scan that a person had. We didn't have access to the biopsies from when they had a hip replacement, or, they wanted a lot of data. And so, we really, we have to draw the line somewhere with what we ask the clinicians and the teams to deliver. We think we do ask a really comprehensive minimum data set, but absolutely we are interested in every single aspect of bone marrow failure syndrome's fertility things, and I guess what we're working towards, what I would like to work towards is if we did get invited to participate in a project about when the pancreas doesn't work in Shockwin-Diamond syndrome, and they wanted certain samples for that, that we could combine the power of the biobank and the registry in a de-identified way, be able to get that data, those samples across to whatever lab in the world is working on it, and contribute. So that's what Melissa mentioned, that we try to be as all-encompassing and we're trying to be as flexible as possible. And we have to work within the regulatory ethical frameworks that we have. But really, we would love to be able to participate in every single project that's brought to us. And there's just so many interested researchers around the world they're asking things of us, and so yeah, we're doing our best to accommodate things.
Thanks, Lucy. Lucy and Melissa, you might like to comment on a question about people. I think people can imagine or understand why things like blood samples or maybe bone marrow samples might be central to something like a new biobank. But what about things like buccal swabs or hair follicles? Why are these important, and why might they be useful in a new biobank? And how do you look after those samples? And why do you collect them?
Sure. So I can speak to this because this is something very close to my heart, and then you can jump in, Melissa. So we know that in the bone marrow failure conditions, that because the blood is sick, it can do strange things. It can show us cancer, and it can hide things from us. And so a very important part of our research is understanding not only what the blood compartment is up to, but what the not blood compartment is up to. And that can be from, the cheek swab, or from the nails, or from the skin biopsies, or from the hair follicles. And, again, in a perfect world, I would, like all of these samples in patients at what we call baseline when we meet them, and get a really good set of samples from a person when they've first walked in the door, and then we don't need to repeat that, because really your skin genetics and your nail genetics don't really change, but it's your blood that, as we know, can change over time, sometimes for the worse, sometimes for the better. So we like a broad range of samples at baseline, and then as we go on in time, person has a treatment, or even we're just monitoring them, we want to see how the blood or the bone marrow changes. So those are the ones that we want to collect into the future. But those, what we call germline samples, skin, buccal swab, nails, hair, they're the ones that we ask for, at the first time that we meet you. Yeah, they can, but we're not fussy about when they come. So if you just, we're having a bone marrow biopsy, and you couldn't face having an eyebrow collected or something that day, we can take them in the post, 2 months later when you might be feeling more up to it. So we've, like said before, we're trying to be as flexible as possible with the samples.
But it's one of the great challenges of biobanking, Erica. Of course, we try and think about what research we want to do in the future, and the way that a lot of people are applying new technologies that we wouldn't have imagined 20 years ago. So we're always trying to think ourselves into the future, and therefore have every possibility really available for the best question there is for each syndrome into the future. A nice example of this is there's so much technology now that can analyze a single cell, a single blood cell, or a single cell from anywhere in the body. And if people hadn't have thought that was coming, we wouldn't have the right specimens in the biobank. So it's always active. What are we going to be needing in 5 or 10 years? And can we collect it now? And how?
How exciting. I've got one more question for both of you. And well, it's really an amalgam of 2 questions. Someone's asked, my family has been involved in genetic research. Is there anything else we can do? And someone else has asked, can I still help if a bone marrow transplant has cured me? Any thoughts on those related questions?
So yeah, I'd like to say yes to both of those things. So I'm not sure, what the person who said their family had participated in genetic research, I'm not exactly sure what that was. But for example, if it was in one of our research projects where they'd had research to try to find the genetic cause of their disease, then absolutely they can go on and get enrolled in the registry or the biobank. So yeah, having the answer we know doesn't, for the reason why you've got the disease, doesn't fix everything. It helps a lot, but it doesn't fix everything. So absolutely people are eligible to participate in the biobank. And look, once you've had a bone marrow transplant, so yes, you are still eligible. You certainly can participate in the registry, because we'd love to know the story of what led to you having a transplant. And then in terms of the biobank, well, I will say yes, but I guess it really depends on what kind of trouble led you to having a transplant. If you had immunoaplastic anemia and you had a transplant, then your blood samples, and well, they're not really your blood samples anymore. It's the blood coming from your donor. But if you had something like a telomere biology disorder or GATA2 or something, and you had a transplant for that, and that's hopefully cured you, that's great. We would still be very interested in things like those non-blood samples that I spoke about, the skin and the nails or the mouth swab, because those genetics. Your genes is still your gene, your DNA in those samples are still your original DNA, whereas that's not the case once you've had a transplant. So those are really good questions. I think they're reflective of the complexity of the diseases and the treatments that we offer to people, and yeah, there's a million different variations of things like, yeah, I've had a transplant. What kind of samples are useful to you? And again, those are all really reasonable questions to direct to either the registry email address or the biobank email address, and we can work with your doctor to try to get everyone who wants to participate on one of the projects.
Thanks, Lucy. I might take the chair's prerogative to add a couple of things. Firstly, thank you for these great questions tonight. I'd also add, as I said before, that you or people in your family might be able to donate blood to help people who need a blood transfusion. You might be able to serve as a peer support for someone or a family member who needs to talk to someone about their experience. And you could maybe write to your Minister of Parliament, Member of Parliament, or the Health Minister saying, bone marrow failure syndromes, they're really under-researched and we need better funding for research in the future. People are very responsive to questions from the electorate, and it's only by bringing things to the attention of a broad group of people that we might be able to get some traction at a national level. And certainly Maddie's vision has been absolutely central in this. I'm sorry that we're out of time. We've got a fantastic lot of additional questions that we could spend all night discussing, but I'd like to hand back to Amy Coote to close the session. Thank you so much.
Thank you so much to Erica and Melissa and Lucy. We are so grateful to have such an incredible network of amazing experts that are happy to volunteer their time to talk about the amazing research and critical infrastructure that Maddie's Vision has been involved with for 10 years now. Just going on from what Erica just said around that advocacy piece to government, I am thrilled to share with you tonight that you may have heard, but Maddie's Vision was successful in getting bipartisan federal government election commitment of $3 million over 3 years, and we're currently working with the department to bring that funding to life. But two of the key elements of that funding proposal was ongoing support for the registry and the biobank. Maddie's Vision has been a proud supporter of these two incredibly important functions for a decade, and really proud to be able to share the progress of the registry and the biobank with you all tonight. A huge thank you to all of you that have also participated in helping inform and shape the sessions. These patient and family educational sessions couldn't be delivered to meet your needs and what you're seeking without your support. So thank you for your contributions. Thank you for the questions that you've shared in advance and your participation this evening. Additionally, I wanted to share that the team will send out a survey to you all. Please do take a few minutes to provide your feedback. Feedback helps us improve. It helps us ensure we're meeting your needs and helps us grow as an organisation. I would also like to say that we have another session coming up for August. That's a really exciting session with the fabulous team at ANU on mRNA. So watch this space. There'll be some more information coming out very shortly about that. So I think that really ends the formalities tonight. You've got the email address for the registry. You've met these amazing, wonderful women who spearhead this incredible work. And please do reach out to the team at Maddie's Vision if there's anything we can do to support you. Reach out to our tele support nurse and interact with our peer support program. We're here for you, and look forward to connecting with you all again shortly. So thank you all so very much.